live from New York. It's Benefits with Friends. I'm your host, Lou Bernardi. Thank you for joining us here today. It is, I always like to give the weather, I don't know why, 22 degrees. It's the high. We're going down to 6 tonight. So nice thing is off to Miami on Sunday for a conference, Sunday through Wednesday. So can't wait for that. I heard it's about 80 degrees down there. And today we have a special guest, Chris Hamilton. I'm going to bring Chris right in to the stream. Hey, Chris, how you doing?
Hey, Lou. Doing great. Good to see you.
Awesome. Thank you. Thanks for joining today. So Chris is a partner. He heads up the employee benefits division at Hotchkiss Insurance, which is in the Dallas-Fort Worth area, right?
That's right. Yep.
So his focus is working with clients who improve profitability and valuation by helping them rein in runaway healthcare expenses, which is why he's on the show today. I follow Chris on LinkedIn, and we've spoken a couple of times, and we have a lot of similarities, like-minded approach to the way we're doing things. And today we're going to talk about something near and dear to me, and I know Chris, the American healthcare consumer, who they are and what strategies are they winning with, because I think you really can't use the word consumer when you're talking about healthcare or health insurance to the fullest extent of what I think that word means. So we're going to get to that. Anything you want to add, to your intro? I'm not really good at intros. This isn't Hollywood or
No, you did a great job. Thank you for that.
I appreciate it. What's the weather there? I'm afraid to ask, but.
Oh, it's a lot warmer than it has been this week. Right now, it's 45 degrees, and tonight we'll get down to a low of 29. We've had freezing weather all week, so we've had a lot of snow and ice. So definitely looking forward to some warmer temperatures. Things you can tell behind me are thawed, but earlier this week those trees were covered in ice. So.
Oh, really? Oh, wow. It's funny. Yeah. We had a dusting in New York Tuesday morning. When I mean like just a dusting, and that was our only snow so far this year. So knock on wood, I hope that continues. My back's not a big fan of snow. So anyway, getting to it, the American healthcare consumer, and I know that when we spoke and we talked about particular topics, you jumped right onto that one. And for me, the American healthcare consumer is many different entities. It's employers who are purchasing health insurance on behalf of themselves and their members. It's the members, the employees at businesses, when they're selecting among the plans that are being offered from their employers. They're a consumer, right? They have to make a decision at that point. And then also they're a consumer with a completely different hat on when they take their ID card and they enter the healthcare system, right? So for me, that at least that's in my mind. Is that similar to what you think of as the American healthcare consumer?
Yeah, so there's a lot of different consumers. Primarily who I identify as the consumer of healthcare is, because we work with commercial health plans, are the employers. The employers are who set the ecosystem that employees have to work within. And so I really believe the ultimate consumer of healthcare is the employers, and primarily self-funded employers. Employees are just buying what the employer set up for them. And I really don't view, I view the members as the ones that decide what they're going to buy, but they only get to choose what the options the employer has laid out for them. And when you think about healthcare, visits and basic generic medications and those things, that's not really what's driving health. It's big facility, imaging, infusion. It's the big ticket items. And for most members, you have any one of those things, you're going to spend your deductible and out of pocket. So you might buy something that's $100, $200, $1 million, and your cost is capped at $3,000 to $5,000, whatever your out of pocket is. So are you really you're making a purchasing decision, but you're not paying for it.
Correct.
So the cost really is the same no matter where you go to the member.
Yeah, I went through this so many times in my brain, and where I landed was this, and see if you agree with this or not. But employers, because that's what we do, same thing. And if you're tuning in, or if you listen to this on the podcast, which will come out in a week or two, wherever, hopefully people are listening, because it's just too important for them not to be listening. Is employers think of themselves, I think, as health insurance consumers, right? They're focused on the cost and what they can afford to buy and roll out to their employees, right? So I actually love the idea of getting employers, I call them benefit decision makers, HR directors, CEOs, COOs, CEOs, whoever's involved in that benefit decision making process as a company. I want them to think about healthcare because that's really what they're buying. They're buying access to healthcare for their employees. But they're so focused on the insurance because that's the easy part, right? It gets wrapped up in a bundle. This is what the cost is. I love the idea of calling them a healthcare consumer, but I don't think that's where their mind is. I think they're buying insurance. They set it, they forget it, and they move on. And then you have the employees, again, they're picking a health insurance plan that their employer's offering. And a lot of the time, they're not thinking about their healthcare consumption when they're making that decision, and they make the wrong decision, right? Mm-hmm. So they're offered. We just finished an open enrollment meeting just before this call today, base, mid, and high plan, and I emphasize so strongly: don't think just about what's coming out of your paycheck. Think about what the next 12 months are likely to look like for you and your family, and the different nuances between all of these plans, because you're a consumer. Don't just pick the lowest plan because you're paying less, and then you enter the healthcare system after the fact, and you find out this is going to cost me what, and you can't change it. So I don't know what you think about that. That's my play on healthcare, health insurance is I want that mindset to shift to healthcare because that really plays into what you and I talk about in the plans that we're offering people. Yeah. So, I don't know if you have anything to add there, but,
Yeah, I think at the end of the day, what I always try to explain to both employers and employees, whatever you spend in healthcare is going to dictate what your insurance costs are. So directionally speaking, the more I spend in healthcare, the higher my insurance premiums have to go. The less I spend in healthcare, the lower insurance premiums can go. And a lot of times when you talk about spending less for healthcare, people think you're talking about rationing or foregoing care. And you and I both know that just about anything in healthcare, whether it's expensive medication, surgeries, imaging, you name it, the things that really drive healthcare costs, you can buy the same thing typically at a fraction of the cost, and sometimes at the same place for a fraction of the cost. And so I always tell CFOs, if you spend half as much for healthcare, you can provide twice as much at the same price.
Right.
And so really it's about understanding what do we spend for healthcare, and then understanding who in the marketplace is able to design a plan that allows us to spend less for the same things.
Yeah. So we definitely, we share at least half of the same brain because it's amazing. Everyone I talk to, when I get together with other advisors, we've come down the same path, right? And it started for me about 5 years ago, but, let's talk about some of the false narratives and misconceptions that we've been, unfortunately, as advisors, we perpetuated some of this, right? Because, to be a consumer, you need to see the data, and the data has been closely held by the healthcare world, the hospital systems, the providers, the facilities, and the insurance world. They didn't want anybody to see the real data because they wanted you to believe. And what do you think about this? I'm going to ask you a question, and it's meant to be silly to us. The claims are the claims, right? I mean, what do you mean? Aren't the claims the claims? Isn't an MRI the same no matter where you go? Isn't a knee replacement the same wherever you go? Isn't the quality the same wherever you go? What do you think about that?
I think that's hitting the easy button. I think it's false. I know it's false. I don't think it's false. I know it's false. And the reason why I know it's false is we have enough clients, our own company included, that are self-funded, and we see what we pay for claims. And it's amazing. I'll give you just a perfect example. And this actually happened, what is today? Friday? It happened Wednesday. I got a claim notification for, and this is one I love talking about, but for dialysis. And we actually have two patients going to the same clinic for dialysis. One of them is on a major carrier network plan, and one of them is on one of the customized plans that we call the benefit insider plan.
Yep.
And the claim cost for that member that's on the benefit insider plan is about $5,800 per month. Do you want to take a stab at what the dialysis treatment for the exact same facility is on a BUCA plan?
I can tell you that because we had one, and the projection was $300,000 to $700,000 per year.
Yeah.
Right. So let's just say $25,000 a month on the low end of the projections.
It's a little closer to
once
30
every 2 days. Yeah.
Yeah. So it's closer to 30 grand in this case. So let's just call it, there's a $24,000 to $25,000 delta per month in cost for the exact same treatment at the exact same location.
Yeah.
Which one of those two employers do you think is going to have a better opportunity to lower their healthcare costs or off-put an increase at their renewal? It's a no-brainer.
It's a no-brainer. And people think, oh, I don't have to worry about that if I'm fully insured, right? So if you're fully insured, you're paying that higher amount. You don't have any negotiating power, right? You have no ability to manage that claim whatsoever. Dialysis is a great example. My first experience with we call our plans Bright Path, plans when we're working with independent TPAs. We still have a network on the plan. However, we have a separate carve out for dialysis.
Yep.
But we didn't at the time that this first occurred. We had an ability we had a plan addition that we could have put on. The TPA we were working with brought it to our attention. Gentleman was about to start dialysis. The cost projection was right there. We have a great option for you. And we were working at the time, this client had one of the major, I don't bash too much here. So one of the major carriers, a TPA owned by a major carrier. So we approached them and said, okay, we're going to carve this out in the contract and allow this member to use the exact same facility, just as you mentioned. You don't have to change the facility, but a third-party agreement with another entity. We're going to bill it through there. We're going to pay it through there. It's going to go through the TPA. Similar numbers as yours. And the TPA said, no, you can't do that. So I said, what do you mean you can't do that? Well, we can't allow you to do that. It's not in the best interest of the member. So I said, we're going to the same doctor. Yeah, but we have the best deals around. I'm like, wait, I just gave you the numbers. I know what you're going to pay. Can you dispute this? No. Well, how is it in the best interest of the member? Well, we can do the pre-certification for it. I was like, well, you can do the pre-certification anyway if you like, but we're going to do it elsewhere. And they didn't like that. What we ended up having to do is change TPAs because they wouldn't even allow us to exclude it. Our backup plan was, let's exclude dialysis, and we're going to have a separate plan document specifically for dialysis over here, which meant we're still covering it. We're just not covering it through that BUCA network contract. But they wouldn't let us do it because we all know the kickbacks that they get from these facilities, these premier partners of them. They're not partnering with these facilities because it's in the best interest of the employer or members. They're partnering with them because they make major financial incentives behind the scenes.
Well, let's unpack this just a little bit, if you don't mind. There were two things that you said. I'm going to work backwards. So you talked about financial incentives. So anybody can research this. You can actually pull their 10Ks and 10Qs, their public financial reportings. Let's just pick on United Healthcare for a minute. I don't mind naming names. We work with them, and we've run into some of the similar issues. But they own a group called Optum. United Health Group owns Optum. And why Optum is important? Most people recognize that name because it shows up on their ID card as a pharmacy vendor, which they're massive in that space. But what most people don't know is they're the largest employer of healthcare providers in the country. They're a behemoth, and they're getting bigger every single day. And one of the things I think is really interesting, particularly when we're talking about dialysis, is they actually bought a group from DaVita, which is the largest dialysis provider in the nation. But Optum actually bought a unit from DaVita. And I think that creates somewhat of a conflict of interest, in my opinion, if I was to look at it. And I'm going to explain what I mean by this, because
Sure.
people will make the argument that these carriers vertically integrate to lower the cost of healthcare. But my question in response to that is, if they're creating value, is it resulting in lower premiums and lower costs for employers and employees? The answer is no.
The answer is no.
And when you look at their financial reportings, the profitability is going up, primarily driven by those units. So if I'm with a major carrier that owns a dialysis provider, and I'm going to charge my insurance company $40,000 a month for treatments or $30,000 a month for treatment, I'm going to have to go back to the employer and say, claims are up. I'm going to have to jack your premium up, knowing full good and well that I really could only charge myself $5,000 or $6,000 and still make a profit, but we're not going to do that. And that's where I see the conflicts in the health insurance and in health care. And so I think that's an interesting point, which leads me to my second point. And I talked about this in LinkedIn earlier this week about the notion of being fully insured. The only truly, in my opinion, fully insured groups that exist in America today are those that are in the community rated pool. And I don't even believe that that's fully insured, because at the end of the day, rates can go up. But let's just say I'm an experience rated fully insured customer, which we have a lot in Texas. And there's nothing wrong with being fully insured necessarily, right? It just depends on what you're trying to accomplish, what your goals are. But what I would tell somebody is, in an experience rated fully insured plan, you're really just delayed self-funded. And what I mean by that is, if your claims experience is high and the carrier doesn't make their profit, they're going to increase your premium at renewal. So what the impact of your claims experience is going to affect your renewal. It's going to affect what you pay in year 2 and year 3 and beyond. So the problems that I see, particularly with fully insured plans, is that the carriers don't give you tools to manage the cost of claims. Going back to the dialysis example, am I going to pay $40,000 per treatment or $5,000 per treatment? Am I going to pay $40,000 per infusion for a cancer patient or $12,000? What do I pay for hip replacements? Is it $20,000 or $60,000? And so there are mechanisms that advisors like yourself and me are using to create an ecosystem that allows employers to lower their cost of healthcare, their claims experience, lower the cost to the company for their insurance program, and at the same time, drastically lower the cost of insurance and out of pocket for employees. It's almost like you're creating this perfect trifecta where the insurance is happy, the employer is happy, employees are happy. I would call it a four-way when the providers are happy. So there's just
Well,
that much. There's just that much meat on the bone out there.
Well, then, it's a great example because, and you're right, unless you're, and community rated, right, your claims don't impact directly your premiums. If you're large group but not experience rated, we have some manually rated groups where it's just the demographics, the average age, the family sizes, the genders, zip codes, right? You could argue, all right, they're insured, right? Because I had one group this year, perfect example, 250 person company, only 50 enrolled because we have a large union population, but they're a large group because their full-time equivalents are more than 50. But with the carrier that we have them with, they're manually rated, and their loss ratio was shared with me because I was aggressively trying to negotiate their renewal. But they had a 246% loss ratio, just claims versus premium. The nice thing is the carrier renewed them. They renewed them at manual rates, but they did not negotiate at all. So it was a approximately 10% increase because that was the book rate. Any group that's fully insured, experience rated, is paying top dollar maximum liability, and they have absolutely no ability. So first of all, we both know they're overpaying for prescriptions by 30 to 50%, right? Rebates, spread pricing, just formulary manipulation, all of those things that a lot of employers aren't even aware of. They're not thinking about. You think your insurance carrier is getting the best rates. You think they're aligning the formulary, because this is where it's a cost. of the medication shuffle, but it's not. It's a profit to the insurance carrier or the PBM or both shuffle, and that's where that's where the rebates are there, so that they'll place it favorably on the formulary, so more people will fill it. Because if you eliminate that barrier, that cost to the member, there's nothing to think about, right? So you have to put it where more and more people will fill it, and that's why you're paying so much more for, especially medications, right? And then on the medical side, you're paying top dollar. You have no guidance, you have no navigation support for your members. The Buca discounts are completely gone. And maybe, I'm writing a book. I always mention it. 2 years in the making, but 30 years of thoughts in the making. And in 1992, when managed care entered the New York marketplace, the rates were simple. The rates were the rate. They hadn't had a chance yet. So you were getting a discount, right? The premiums were lower. But over time, somewhere along the way, the executives, those people in the boardrooms, understood that they have such an advantage by keeping the back to the consumer in the dark. It has been intentional, right? You're not allowed to see the prices or the negotiated rates, confidential, right? That was the narrative. We've been selling it as advisors. No, you can't see what it costs. Those contracts are confidential. They don't want one doctor to know what the other doctor is making, because then all of a sudden they'll all want the top dollar, right? Well, they're just giving the top dollar away today, because it doesn't behoove the insurance carriers to negotiate prices on behalf of the members. They want to pay higher claims, so they can charge higher premiums next year. And that was one of the flaws of the Affordable Care Act, which really just, escalated that so profoundly, because it just changed the math. And then you have no ability to do some of the other things. Like you're paying top dollar for medical. I'm going to have someone on the show in a couple of weeks from a company called Slingshot. What Slingshot does is it taps into the claims, and they look for, it's all automated, AI. They go in, they see all the codes, and they identify all of the up codes and the unbundled bundles, where you're getting charged for multiple procedures within one bundled procedure that should be, let's just say, $5,000, but the facility is unbundling it and charge $12,000. We can't do that, and it's not very regularly caught by the insurance carriers. They've been running their program for about 6 months, and 60% of claims have upcoding issues on them.
Wow.
I said, no, you're missing something. You're missing another 30%, because I know it's 90%. I know it's 90% of the claim. It might be 100% of the claims, right? And all of these other things. So let's get back to the term consumer for a second, right?
Okay.
Because when you think about consumer in any other aspect of the economy other than healthcare, the consumer has data. They have information to make informed decisions, right? So you and I both know the data now is pretty plentiful. Most people still don't even know it exists. Most advisors don't even know it exists, because their focus is still on the insurance cost, because it's simple. You get a package delivered to you. It's all nice and bundled with a bow tie. Do not open, because you're not going to like what's in there when you start having a conversation with Chris or with Lou, right? And how do we, or how have you changed your dialogue in order to open up these conversations? Because I would imagine you have experienced what I've experienced, which is it's a lot. It's a lot to take in for a benefit decision maker who's been doing it the same way for 25 years. And now we're saying it's all been smoke and mirrors, and we can do better together. How do you go about that?
It's a constantly evolving process. What I have learned is trying to explain how all of the moving parts to the intricacy that you and I understand them to an employer, it creates fear and indecision.
Yeah.
I also get a frequent piece of feedback from a lot of employers that we work with, that my employees aren't going to understand how this works, and they won't remember to use it when they need it.
Right.
So there are two things that we have done that we've had great success with to make it where employees don't have to remember, and it's a seamless, easy process and decision for them to make. And that is, I think you maybe mentioned it earlier, is the pre-cert process. We have to own the pre-cert process. And for those that are watching or listening to this, the pre-cert process is simply where your doctor needs to get approval to do a procedure or a test. It's super common in the industry. Anything that's expensive that's going to be done in a hospital, doctors know if I'm going to operate on Blue, I need to get that approved by the insurance company. And when the insurance company receives that, that's the pre-certification or pre-authorization that gets the check of approval for the doctor to do his procedure on Blue. So what we do is we take ownership of that process. We have vendors that we work with that will take care of that. And the second piece of that is they now become the navigators for our employees. So to explain this very simply, I'm actually going through this myself right now. Employees will have access to a national network that they will, every doctor and hospital is going to recognize. It's, one of the big four probably. And if they want to use that ID card wherever they go, they're welcome to, but they're going to be subject to their normal deductibles and out of pockets. And for mid-sized employers, deductibles may range from $2,000 to $5,000 in out of pockets. So an employee is going to have a major surgery done or expensive medication, it's probably going to be subject to a $5,000 cost. Let's just use that math.
Sure.
So at the time of that pre-certification, this is my example right now. I have to have a procedure done in a hospital. I have to have a surgery to fix something. And so that pre-certification process is going to happen. The nurses are going to see that this procedure needs to be done and approved. They're going to pick up the phone and they're going to call me and they're going to say, Chris, we see that you need to have a procedure done. We want to let you know how your benefits are going to work when you show up on the day of the surgery. You're going to be responsible for your $5,000 out of pocket because likely the procedure is a $20,000 or $30,000 cost. Okay. But if you're willing to let us coordinate your care, it's likely going to require me to get a second opinion from another surgeon. But if you use our pre-certified highest quality doctors, if you use them for this procedure, we can waive your out-of-pocket costs. And so now the surgery becomes free. I use air quotes, free to me as a consumer, as the employee, the member.
Sure.
And my health insurance plan is going to save a tremendous amount of money because it's likely we can source that surgery for 70% less. And in my particular example, which I'm going to share this openly on LinkedIn, I've already selected a doctor. The doctor I was seeing had a 91 quality score. It's using CMS and other claims paying data, how many rates of infections, yada, 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 all that stuff, right?
Right.
But the doctor through my care navigation program is a 95 or 96. So one of the highest level providers in this particular surgical specialty. So I'm actually going to see a better doctor than I normally would have seen, and the cost is going to be waived to me. So to kind of sum that whole thing up from a consumerism standpoint, this is what I would say to HR owners and CFOs. We can align the interests of your employees with that of the health plan to help them become good stewards. And the way you do that is give them a choice. Use your normal benefits as you would, or you can get your healthcare for free going through this other channel. And particularly in today's economy with gasoline and food and mortgage and rent and all these other costs that are exceedingly increasing, employees want a lower cost alternative. And in many cases, it's a financial lifesaver to them. So it's a win for the employee, makes the employer look good that they're even offering a free option, and the employer wins at the same time. So it's just kind of the best of both worlds. So it kind of solves for making it simple and making it affordable.
This is why I knew I had to have you on the show, because I think we speak very similarly. You just explained that so my daughter could understand it, right? And here's my takeaway from that. What you talked about was a choice, plan design, right? So it's appropriate plan design. There's nothing complex here. You're not asking employees to bear, or their employer, right? You're not asking for an HR team or CEO or CFO to get involved with the benefit decision or the healthcare decision-making process, right? I agree with you. I think that majority of the time when we talk to benefit decision makers, they like to maybe hide behind perhaps the fact my employees won't understand that. But I think that's a cop out, right? I think that's like that to me. I hear I don't want to learn it, but and I'm just
Yeah.
going to throw that right out there. That's what I hear a lot of the time. They buy other things. Americans are the best consumers in the world. We can buy anything. I can find the best price for just about any product you tell me in 10 minutes, and I'll be able to make a choice and buy it from maybe where I'm going to get it the quickest, maybe where I'm going to get it the cheapest, maybe from a seller that just had the highest rating, but I can make that choice as a consumer.
Mm-hmm.
So now what you just said was you're having a procedure. You don't have to do anything, and you could because you're an advisor. You're a forward-thinking advisor, but you don't have to because you have the tools in place within the plan design to give you the option. You could still go to Dr. A if you wanted to, right? You could make the choice to pay the $5,000. Some people might. It's a 91's not a bad rating, but you were given the choice to see another doctor as high or better quality. And that's just the doctor. Now, the hospital is even a separate, right? I'm sure that's part of it too. What hospital? Doctors have admitting privileges to multiple hospitals. The cost of the hospital, the anesthesia at the hospital, the cleanliness at the hospital, the infection rates at the hospital, that's all taken into consideration when you're talking about using like a clinical case manager, right? That gave you the choice. They probably even made the appointment for you if you said, I'd like to use Dr. B, right?
Mm-hmm. That's right.
And now you've saved money, which is really not the point. The point is you had a way, finally, which doesn't exist for most people today, to locate and access the highest quality doctor. And just to kind of reiterate that. So where does that come from? It's not just someone saying we have good doctors. These doctors don't work for your clinical case management company. I am sure they're using data. There's billions of claims every year that are released from all the commercial insurance companies, Medicare, Medicaid, VA, everything. And they're shared. And technology companies have figured a way of analyzing that data. It's done slightly differently, but I'm sure a lot of the assumptions that they're using or data points that they're using are very similar. You want to use a doctor who doesn't over prescribe opioids and medication, doesn't do 1,000 surgeries just for the sake of doing a surgery, right? Maybe a doctor that did 200 surgeries with the best outcomes is better than the doctor who did 1,000 surgeries because there wasn't one patient that walked in his office that didn't get a surgery, right?
That's right.
And unnecessary care is another thing. And I'm sure that goes into the calculation, but you're talking about quality. You're talking about being able to make an informed decision. And because of that, let's say your doctor that you saw first was a pretty lousy doctor with a 40 rating, not 91, 40. If you go to that doctor, your chances of getting an infection or having a horrible recovery, lengthy hospital stay, rehab, whatever, we didn't talk about what it is and we don't have to, but all of these things that happen after the procedure, because you went to the wrong doctor, they add up. They cost money. I would rather, and I'm sure you would rather, I'd rather pay more money to get to the best doctor. We're not eliminating that choice. We want you to know who the best doctor is. And maybe the best doctor was one that still cost you $5,000, but you went to the best doctor and you felt good about that decision. For me, I personally haven't experienced the need, but I know if it's one of my loved ones, this is crucial. And to think that over the past 30 years, people have made this decision based on Google searches and word of mouth is just mind-boggling.
Yeah, that's actually what we found is the most common way people find a provider is ask a friend. So there's not very much quantitative analysis, it's qualitative. Hey, Lou, I knew you had to have this procedure. Did you like your doctor? Yeah, great. Give me his contact info. Yeah. And I think there was a couple things that you said that really resonated with me. When we start talking about costs and consumerism, the ability to buy something and you can research it, the data is readily available. And if you just search Bureau of Labor Statistics inflation data, you'll find a chart. There's numerous charts out there that show various items in our economy over the last 20 years. And if you look in most of those charts, healthcare services or hospital services specifically are the most inflationary thing in our economy that the BLS tracks. and that trajectory is straight upwards. I mean, it's a 45 to 60 degree upward trend. But when
Yeah.
you compare that and overlay the data with other things in our economy, like televisions and software and computers and cars and those other things, it's a stark difference. And when you think about the dynamics of those industries that are so different, right? So let's just take a television for an example. That's deflationary. And you remember what the first plasma television cost when it came out into the marketplace? Like $20,000
Yeah.
probably.
I didn't buy
And
that.
you can't even get a plasma television anymore. You can get an LCD TV, LED TV, massive one for just a few $100. But
Yeah.
what's interesting about that particular market from a consumerism standpoint, right? There's multiple outlets of distribution. I can get it in person or online. I can buy it on Amazon. I know I can read quality ratings. I can see how it's priced at various places, and I have multiple ways I can pay for it, whether it's cash or credit, or I can, I can put it on a credit card. There's various ways I can pay for it.
Sure.
And I think those are the dynamics that create a competitive marketplace that don't exist in healthcare until now. And the government, people bemoan government involvement in various industries, but I believe healthcare and health insurance is one that there needs to be some intervention because people have talked about it. We've tried the private free market system in healthcare and it doesn't work. Well, let's back up a second. It's not a truly competitive market. It's an anti-competitive market. There's very few people that control most of the power. And so when you start talking about pricing and quality and ways to pay for things, there's not very many ways to do it. So the question that we had to grapple with over the last several years is there a way to insert dynamics of competition and consumerism into healthcare to drive prices lower? And the answer is yes. And I just described how we do that. We give those in the marketplace that want to compete. There are doctors and hospitals that truly do want to be part of the solution and offer better terms and pricing for procedures. And so we incentivize people to go to those providers and facilities by passing on the savings to the employees, by giving them free healthcare. And so one of the ways it's become very popular in the health insurance space for carriers to address this issue, and this is what I think benefit buyers or benefit decision makers, as you describe them, have an issue with. It's by narrowing the network, removing out of network benefits. It's really coming down to narrowing the pathway for employees to access healthcare. And there are a lot of people, understandably so, that don't want to limit the options that their employees have. So the approach that we've taken and had great success with is saying, you know what? We're not going to limit the choices that people have. We're actually going to give them more choices. And we're going to incentivize them with the carrot or the stick to make the decision that we think is the most financially prudent for both the member and the employer. Both win in that scenario. So it's actually telling the story of how we're going to give people more options. And when you look at a network, so just think of any of the big insurance companies that you can name, they compete on having a big network. Well, Lou,
Sure.
you and I both know that inside of a big network, if I contract with all of the doctors in a big city, let's just take Dallas and Fort Worth. If all of the doctors are in my network, which that's kind of the case now, it's like a 98% network rate. Well, I probably have the best doctors in my network, but guess what? I also have some really poor doctors as well.
Sure.
So what if there was a way to make sure that your employees sought care from the very best doctors at the lowest possible price, and they get a benefit for doing so, meaning we waive their cost of care, which I think the most forward-leaning employers are leaning that direction because they realize it wins for them financially, it wins for the employees, and it sets them apart from their competition when trying to attract top talent. Because I tell you this, we work with mid-sized employers that are trying to attract talent from Fortune 500 competitors, whether it's a CPA firm that wants to pull somebody from one of the big accounting firms, or an oil and gas company that wants to attract talent from one of the big, Halliburton, Schlumberger type companies. They always used to say to us, our benefits are our Achilles heel. We have to pay our employees more to get them because our benefits are just not competitive.
Right.
So I now go to those employers and say, well, what if we actually made your benefits a competitive advantage and we lowered your costs at the same time? And most people, you would think I was speaking Mandarin. They're like,
It's
what?
impossible. It's
It's
impossible. You can't
impossible.
do that. Well, because that's one of the other flaws, right? One of the flaws
Mhm.
is, and it's habit. Somewhere along the line, and in my book, a lot of the things we're talking about today, they're just, we probably, if you wrote a book and I wrote a book, you'd be done first for sure, but it would probably be very
I don't know about that. I don't know about
here,
that.
here's the sequence of events. Managed care came out. They were more competitive than indemnity plans, so much so that the employer, the consumer, the insurance consumer, said, we know this is going to take work. We know this is going to involve education. We don't know what a copay is, but we know what less money is, and our employees are going to like a $5 copay because that's what they were in year one, even a zero copay back then. So they did it, and they put all the indemnity companies out of business. And then those books, because this is my 30th year, and I used to walk around New York City with like 10 directories, sweating because they were printed. Nothing was online back in the day. And if your doctor wasn't in the book, that plan was terrible. If the owner thumbed through the book before we had any say, the owner, the CEO, the COO, the CFO, they all thumbed through first. Once they gave the okay, this is a good plan, my doctors are in it. So the consumer has told the insurance companies for 25 years, we buy networks. Now, that doesn't mean some people don't buy skinny networks because they're cheaper. And some people have, there's a budget. There's only a certain budget you can do. But then copay started going up. Deductibles started getting reintroduced because there weren't deductibles in the early HMO style plans. They got reintroduced because they had hit the peak of what copays could be. So they had to figure out a way. How do we water it down again a little bit to offset the increases we need, because we want to make more money by charging more premium? And then they introduced, and you said it before, consumerism was introduced. That's very different than being a consumer, because consumerism in health insurance was the stick, right? The narrative was premiums are going out of control because utilization is too high, because out-of-pocket costs are too low, and people are just going to the doctor too much. It couldn't be that they were charging more and more and building in all these artificial premiums. We couldn't see that. So this made sense. Oh, yeah, maybe I do go to the doctor more than I did before. So they introduced consumerism, but consumerism is a negative reinforcement. Deductibles became higher. Copays became higher. Out-of-pocket maximums have increased. That's the only tool that most advisors and employers have today, or at least they think they have today, to offset next year's increase. But you and I know that because of all the data and all of the different, I call it like there's an alternative universe of healthcare and health insurance. Providers that want to work with people and employers directly outside of the health insurance systems and the health, and the networks. And all these other solution partners that can get people to the best doctors. They want to be able to say, hey, if you go to these doctors, they're the best. And the best doctors, even if they're more expensive, are less expensive over time because they treat people, they cure them. It just so happens that when you deal directly without the insurance company, they're also usually pretty less costly for the most part. But now we're talking about a new form of consumerism. And that's what you and I are really trying to get past, is that forget about consumerism, forget about all of these flawed strategies and misconstrued solutions that you've been fed. The data tells the truth. Data doesn't lie. And the data is, we can enhance the cost and quality of the benefits you provide and get your people healthier, happier, and make you that employer of choice. Because if you take, let's just say, a traditional high deductible health plan, which might be the base insurance plan that you were describing for you, right? A $5,000 out of pocket. But you have option B alongside it. That's better than any employer that just has option A. What you're saying is, we want to take care of our employees. We want to get them to the best doctors. And of course, we want to lower the cost, because if we lower the insurance cost, or just the total cost to provide healthcare, because I hate calling it insurance because when you're self-insured, it's not all insurance, right? But we want to lower the cost to finance the healthcare risk of your employees. And we can do it by putting positive reinforcements, positive consumerism back into it, and actually educate your employees. When you show someone the price once, the next time they need care, they're going to ask, right?
Yeah.
You're not just going to wait till your insurance company calls you the next time you need a surgery. You're going to be like, what's taking them so long? I'm going to pick up the phone. I want to know where I can go and have the best quality care at a fair price. You're going to change habits, and you didn't have to go to that much length to do it.
Yeah. So since we're on the topic of consumerism, and you mentioned high deductible health plans, I wanted to share with you. I don't think we've ever talked about this, but HSA, high deductible plans. As you start talking about zero deductible plans with low or no copay through the original managed care, and then eventually they had to water the benefits down. Well, think about the early 2000s when insurance costs were continuing to escalate. What was the next iteration of that? We're going to give people plans with no copays and higher deductibles, and we're going to allow them to save money on a tax-deferred basis, and they're going to become consumers of healthcare. They're going to start looking at what things cost, which in theory sounds great.
Sure.
And initially, when I got into the health insurance business, I thought HSAs were awesome. I think they are a good tool for the right buyer, for the right consumer. But what we have found, and I've become kind of an anti-HSA type person, and I debate this with some of our clients, is because I've noticed the people that are buying HSAs are typically lower earners that do not contribute to an HSA bank account. And it tells me they're buying the HSA for the wrong reason. It's the low premium. And ultimately what we end up seeing, and the data has played this out because a lot of our clients that are self-funded, we have access to see who are people that are at higher risk and what are their consumption patterns of healthcare. And so I can see what are called gaps in care. And I can determine, are people missing doctor's visits? Are they foregoing prescription drugs? So if I know that this person A is diabetic and I know they're taking 2 or 3 specific medications, I can see, are they filling these prescriptions at a repetitive pattern, or are there gaps in their fills? And sometimes you'll see people that will go, instead of filling their prescription every 40 or 30 days, and maybe 45 to 60 days between fills, which is not healthy. And it's because they're having to pay for the costs out of pocket. They're sacrificing because they don't have the money to pay for healthcare. And so in my mind, this is something I've changed my mind on, is I now believe HSAs are a good tool for the right buyer. And if educated properly and people are willing to put the money into an HSA account, they can be a good vehicle. But for the majority of kind of the average employer that we work with, it's not a good fit. They'd be better served by having a higher deductible copay plan priced similarly to an HSA, where we give them options to waive their out-of-pocket expenses by going through a directed channel.
Yep.
So you give them a choice.
Yeah, there's no right or wrong, right? There's no silver bullet for this. There's no holy grail plan. People profess to that, but there's a lot of ways of addressing this. At the core of it, it's people need the ability to get to the best doctors, and so you talked about care avoidance, right? One of the things that I've gone through is the type of plans that like you said, we have a lot of fully insured plans, and so do you. It's not right for everybody. Not everybody's, and even if it were right for everybody, not every client's ready for it. And we have to appreciate that, right? Self-insurance comes with a lot of stigmas. A lot of people tried self-insurance 10 years ago with the BUCAs and got destroyed because they didn't address the biggest problem was they were paying those artificial costs and all those hidden profits still, right? So we're asking them for a second chance. We're asking them to trust us with companies that aren't the big 5 insurance companies, right? And that takes a little bit of, the case studies. And we have the case studies that are off the charts, but there's some convincing to do. But what I realized is, and I'm sure you did too, just from our conversation, is that we didn't want to leave our fully insured groups in the dark. We don't want them to be completely at the mercy of these healthcare systems. We might not be able to eliminate the artificial cost and prices, but we still can give them the tools so that they can see outside of the insurance company using a let's call it a plan supplement or add-on. We can give them this guidance. It's really all of the things that the fully insured carriers should and would do if all their incentives weren't misaligned. This is what insurance should be. This is what healthcare should be, right? Talking about healthcare, because we talked a lot about insurance, but going back to, the early 90s, most providers were independent. Most hospitals were independent. And there were true discounts, right? These managed care plans actually were paying less for providers. You were getting discounts. So those hospital facilities initially, and some real savvy doctors, they realized, well, listen, we need to merge. We need some leverage. It's about leverage. And right now, the insurance carriers have all the leverage on behalf of their members. Oxford, United Healthcare, Aetna, Blue Cross, all of these companies, they have millions of members, and we can't do without them. So we have to accept these contracts. So they merge. Hospitals merge with other hospitals. Now you have some states, I think California has one hospital system that might have 40 or 50 hospitals in it. I don't remember. But New York, we have a real large, it's the largest employer in New York State. It's 30-something hospitals. But then they did something very interesting. That wasn't enough. And you can't sell insurance if you don't have that hospital system. You're not going to get much business because network is king. Consumers still focused on network in many cases. But they merged vertically now. They realized we're going to take over the facilities, the labs, the radiologists, the urgent care centers, all the way down to the primary care doctors, which was the key, because that's the gatekeeper. Now they use the primary care doctors that work for the healthcare systems to upsell everything. That doctor, chances are, is probably prescribing more, but I'm not going to go there because doctors are good people. I refuse to bash doctors because they're working within the same game that we all are, right? It's not our rules, the rules that have been written for them, and they've made their decisions based on how they were being treated by managed care. They don't know that MRI that they're sending someone to is going to be $3,000 when there's a $600 option down the block. And neither does the patient, and that's the whole point. And if you have a company with 200 people and you have 30 MRIs next year, and you're paying $3,000 on average a pop, this is $90,000 if my math is right. I might be wrong, but it's a lot of money. Instead of the $600 equal quality, and that's just one type of test. Now we're talking about surgeries. We're talking about all this other stuff. So it is imperative that employers, even fully insured employers, realize that they will never gain control, and actually it will get worse. And the reason why it will get worse, and you touched on it before, because of the data, the healthcare systems and the insurance companies know that their days are numbered. The American healthcare consumer, is going to be reawakened. It might be very slow because they're going to resist it as much as possible. But eventually the numbers are going to get out there. They're going to get the tools. The consumer is going to be savvy, and they're going to see what these two monopolies did to them, right? And they're going to start taking away current profit centers. PBM, for example, there's a huge Department of Justice investigation going on right now about the business practices of pharmacy benefit managers. Some of this hidden profit and artificial prices is going to dry up. But we're talking about companies that are all publicly traded. They have to invent new profit centers. They have to invent and create new layers in the supply chain where they can hide money because they're smarter and their data is much better. The data is not new. The data is plentiful. It's just that the people that could really use it the most, the consumer, haven't had access to it. They know exactly what's happening. The insurance companies can tell us exactly how much business they're losing. And if it's 1%, that's going to get their attention. And I know it's getting their attention because their language is changing. They're starting to use the language of true American consumers, even though it's not really their intention to change the way they're doing their business. What are your thoughts on that?
Yeah, I think you hit on a bunch of valid points that they're, particularly with them creating new profit centers. So one of the things that we see carriers doing today, and I hit on this all the time, is really educating employers on the healthcare supply chain. And so you're now seeing health insurers get into, they're vertically integrating into the provider side. So I mentioned Optum, they're the largest provider of physicians and providers, medical practices nationally. And you look at how they're getting into primary care, and they're getting, not just Optum, but the others, each of them has some variation of getting into primary care. They all own their own pharmacy contracts. In the case of Aetna, they were purchased by one of the largest PBMs, and that has to be due to distribution. And so the way I look at insurance today is the insurance is simply the platform to be monetized.
Yeah.
And from that standpoint, when loss ratios are really high, meaning there's, if I take in $100 in premium and I pay out $99 in claims, the profitability of health insurance is really low. It's 1% in that case. So premiums have to rise, right? But what I don't show you is that of the $99 spent, the companies that I own retained 40 of it or 30 of it. So said another way, I always use analogies. If you consider healthcare a custom home project, and you hire me, Lou, to be your home builder, and I tell you that I'm only going to make 15%. It's a cost plus project. I'm going to make 15%. And I initially tell you that I budget the house is going to cost about $1 million. And then 9 months into the project, I come back and say, Lou, I'm sorry, the price of the house has actually gone up 30% because concrete, steel, lumber, and roofing materials, plumbing, all those prices have gone up. Well, now I have to raise the price of the house 30%. But what I fail to tell you is that I own the lumber supplier, the plumbing company, the foundation company, and the roofing supplier. I fail to tell you that I own those. And by the way, I've overpaid all of those subcontractors myself by the tune of 30 to 50% more than I should have paid. And I'm not going to show you the invoices either. It's just that's the cost. I'm going to show you my general contractor invoice. And that's exactly how health insurance works today.
That's exactly right. And you know what? And it does probably happen in home building because, you can't do it yourself. Most people can't do it yourself. I'm handy, but I can't build a house. But, the shame of it is that in that situation, at least, that home buyer knows they're the consumer, right? They know they're the consumer. The healthcare consumer, insurance consumer, they don't feel like a consumer. They feel like they have absolutely no choice, that this is just the way it is, and we're going to have to deal with it. We're talking about giving an employer, a 200-person group is in the millions, right? 200-person group can spend $3-4 million on insurance, depending on the quality of their insurance plan. That's a lot of money. It's almost always their number one negotiable operating expense that they have completely given up any chance of negotiating. But it is negotiable. They think they only have the ability to negotiate the way they've been negotiating it. 15% increase, I can get it down to 10. Now I can make some plan changes. What they fail to realize, and what you brought up, which was great, is that you get that financial analysis with your renewal. What we like to ask the insurance carriers and the underwriters is, let's see a couple of other reports. How much of the $1 million in medical claim spend that they made was at your insurance carrier owned facilities? What are the rebates on the medications, that $600,000 medication spend? How much of that? Send me the rebate report. I want to know how much you earned on that, because you're not showing me the real loss ratio. I talked to an underwriter for one of the largest, probably the largest insurance company. He's at a TPA now. I had a great conversation with him, and he had insights that were mind-boggling. The things that we know, he knows. Like, he knows to the depth of what they're doing. The worst cases, the cases with the biggest loss ratio, are often the biggest money makers for the insurance company because of all of the backdoor deals. And those are the conversations that, as an advisor, that's my job now. You can't just accept the strategies that haven't worked for so long, right? My goal is to create, and I'm sure yours, a 3 to 5 year plan. Meet an employer where they are, educate them, inform them subliminally if necessary, right? I mean, I appreciate how busy they are, but they will never get this under control unless they are better equipped to set their expectations properly. They need just enough lingo to make their benefit partners uncomfortable, right? The conversations that you and I are having today, your own customers, right? You can't talk this talk unless you're walking the walk, right? You have to be able to back it up, and if they're fully insured, great, fully insured, but we're not going to just, give us your best offer. No, you can't do that anymore. We reconstruct the renewal. We plug our own pooling charges, credibility, weighting, all of these things. We don't just accept the numbers that they give us because they're made up. They're completely made up. I know that for a fact. None of these numbers are real. It's just to build the narrative that's going to allow them to present a renewal of X amount. And that X amount also is contingent upon who the advisor is. You have a history with that carrier. If they know that Chris is a guy that can get 10% off when everybody else can get 6% off, well, guess what? They're starting you at 4% more. I'm sorry, right? Because they know you're. That's why you said it before, constantly evolving, constantly educating, really keeping a pulse on the healthcare world, the health insurance world, seeing what's happening behind the scenes. So much has happened. We could talk on and on and on. We're just at the hour mark now. I don't know how much more time you go, but this is usually where we kind of have our final thoughts. I mean, you've been a great guest. We could probably talk for 3 hours, but no one's going to listen to it for 3 hours or an hour. But maybe they'll listen to 20-minute segments here and there.
Yeah. I guess the final thought that I would share with your audience is there is a path forward that truly does generate lower costs and better benefits and more choice for employers and employees. And it really requires somebody just to have an open mind, to work with an advisor that knows how to do it. And I truly don't believe the path that we're on is sustainable. I don't know how many more 15, 20, 30% increases that employers are going to be able to take. And so I believe that healthcare is a vital part of our society. The healthcare piece is.
Yeah.
I mean, and our society benefits when we have access to affordable healthcare. And it's going to be reliant on people in our community, which is the brokerage community, the benefits brokerage community, to be able to be forward thinking enough to see these options and to deliver them to employers. Because if we don't, the outcome to our society is going to be detrimental, in my opinion.
It's going to be horrendous, and it's going to escalate because as more and more employers do become savvier, that take advantage of some of the things that you and I want to talk to people about, the people left with these ancient plans, these traditional plans, are going to pay their share of it. The insurance companies are not rolling over. Wall Street won't stand for it. They have a fiduciary responsibility to maintain their earnings at the end of the day. And that, that's something you have to be conscious of. So anyway, thank you.
I'll share two things with you really fast. If you might.
Absolutely. Yeah. I don't have anywhere to go.
When people are looking for the source of the solution, you can't look to the people that help create the problem and who profit from the current state of the problem. So you have to ask yourself, I always try to educate employers to understand everybody's financial interest in their deal. Because if you understand how people make money, you understand how their deals are going to be structured and how to navigate the landmines, if you will. And one thing I would leave everybody with, I love using this analogy. Do you remember the first time you saw one of these? An iPhone?
No, what is that? Just kidding. No, I don't.
Yeah, it's an iPhone. So back in the day, everybody used to have a flip phone, right?
Yep.
The Moto Razr X or whatnot. And when this was shown to everybody, there was a portion of the population, probably about 20%, maybe 25% of the population that knew exactly what it was. That's my life in my pocket. It's my social media, it's text, it's email, it's web browsing, it's my video camera and picture library. It's everything all in one, right in my hand. But then there was probably about another 50% that didn't quite understand it, but with some convincing, they came along to understand it. And there's probably another 25% that was like, oh my gosh, it doesn't have keys. I'm not ever going to use it. But guess what? Walk around and see what kind of phone everybody has in their hand today. It's one of these without keys or an Android that doesn't have keys either. My point is, I truly believe in the next 5 to 7 years, it may take 10, in the next decade, everybody's going to have some variation of the plans that we're talking about. The question is going to be, who are the early adopters that have the ability to set themselves apart and also the ability to save a decade's worth of money that's not overspent? Think about the treasure chest that can be built, the war chest of savings. 100 to 200 life group, literally over a 5-year period, can save $1.5 million. That's feasible, if not more. So
Absolutely.
how impactful is that being reinvested into your employees and being reinvested into your business over the 5 years? So I'll leave you with that.
You know what? And that's a great way to end it. It's all about leverage. And for the past 30 years, the American healthcare consumer has been the leverage that the insurance carriers and the healthcare systems have used against each other. It's time for the American healthcare consumer to take the leverage back. They have the leverage. They can change this market just like that phone market changed. Blockbuster's not here because the consumer decided. What was it? The first online taping thing, Cablevision taping thing. What was that called? Where you can just tape it, and then you can get the movies online. It was called something here, but it was essentially Netflix. But there was an earlier, brand of it. The consumer decided that. It wasn't Blockbuster to decide let's shut our doors. Where the consumer takes their business is where business is done. And if the consumer wants to deal with this, they have to understand their role in it. They have to spend enough time. They have two choices. They really have four choices. Keep doing what you're doing now and see how that is. Your prices will double in 5 to 7 years, your premiums. And do you have a problem then? If you don't think you have a problem now, your premiums are going to double in 7 years. Do you have a problem with that? Or they can spend 8 hours a day for the next 3 years educating themselves to learn everything that it's taken me close to 5 years. And every single day I learn something more. Or they can hire someone to help them do it. But the important thing is they have to understand why they're doing it, and they have to elevate their expectations so that the partners that they're working with are meeting them. Set your expectations higher. Otherwise, you will continue to get 10, 15, 20. We have a prospect right now, unfortunately, another 30% increase, and they're going to renew. They're going to go right down the exact same way. 4 years of talking with them, and it's so unfortunate because they're so busy. They're not too busy just to understand it. I've had calls with them, but they're just their mindset is not right. But next year will be the right year. It has to be. Their employees cannot absorb more, and their business cannot absorb more, and there's nowhere for them to go. They've hit the plateau of where their plans can take them already. And for me, I won't stop asking them because it's about their people. I love
not only is it about their people. I feel bad for companies in that situation. I genuinely do, because even if the company absorbs that entire 30% increase, employees don't pay any more than they already are. It puts the company at a competitive disadvantage to their peers.
Absolutely.
So if you're a contractor and you're bidding out your work, when you're having to allocate your cost to determine what you bid for a job, the insurance is going to get baked into that cost. And so now you're putting yourself at a competitive disadvantage, which is ultimately going to impact the company, which impacts the employees. Maybe there's a job that they don't get because of it down the road, which is going to force them to lay people off.
Layoffs, absolutely.
I just genuinely feel bad for companies that are in that situation. I genuinely do.
Yep. We're in the same boat. Well, anyway, thank you I'm glad we got this done. Enjoy the little bit warmer weather. I'm heading to Florida on Sunday, so I think it's gonna be in the 70s. I can't wait to do it. But this has been great. Thank you so much. I'm gonna end the broadcast there, and you can stay on. We can chat for a minute if you want.
Yeah, sure, absolutely.
See you in a bit. Thanks.
Mm-hmm.